So what is the evidence for this? I will go just a couple more minutes, and we'll have a few minutes for questions. Nicholas Kristof had a very nice piece earlier this month. He wrote that 56 to 60% of people in government-run Medicare rated as a 9 or 10 on a 10-point scale. In contrast, only 40% of those enrolled in private insurance ranked the plans that high. This is the government taking over your health care. People like it better. Throughout the industrialized world, there are a handful of areas where government still needs better than free markets. Fire protection, we have public fire protection. We didn't used to, now we do, which works much better. Police, education, postal service, libraries, healthcare, I would add to this highways. The United States goes along with this international trend in every area but one, and that's healthcare. Here's how the US stacks up against other OECD countries. If you compare, this is actually, Will, I'm going to grab you after the talk to see if I've got something here. I just did this. I took data from the OECD on the consumer out-of-pocket spending as a percent of all health spending. How much of all health spending comes out of our pocket, out of our wallet, and compared that to the healthcare spending as a percent of the economy, percent of GDP. And this is what I got. The two outlier countries, one is Mexico, which in the next slide I'll drop because I think it's atypical of these countries, and one is the US. And of course, we're spending much, much more as a percent of the economy, up to 16%. We actually have, by this measure, and it's an imperfect measure of the burden on individuals, but by this measure, we actually spend less out of pocket than other countries do. This doesn't include what we put into premiums. This is just out of pocket at the time of service. So as you can see, we're way up there. The difference between the US and the rest of the countries is the administrative costs, it's the prices, and it's the use of expensive technology like MRIs. What happens if you look in detail without the US, because I think it's not like the other OECD countries in terms of its healthcare financing, and without Mexico because the economy is completely different. Well, if you do a regression analysis, which is trying to look for a trend in these lines, is there an association between how much consumers spend and healthcare spending overall? And the answer is no, it's a flat line. And then statistics there kind of back me up. So what this suggests is, while there may be savings for specific services where you charge people more for that titanium hip instead of the traditional hip, the overall, there's no evidence that I can find that at the health system level, making people pay more out of pocket actually changes the cost of the overall healthcare system. So, unless Will tells me that I've done the regressions wrong, that's my story. I want to end actually with a non-economic, non-numbers thing. I'm a research professor at the university. When I want to do research that involves human subjects, I need to get approval from something that's called the Institutional Review Board or the Human Subjects Review Board. So if I wanted to do research, say, on health insurance, and I wanted to assign people to different health insurance, I'd have to go to them and say, this is what I want to do, this is why I think it might work, here's the prior evidence, here are the theories, here's how I will protect participants from harm. Let me propose to you that what we are doing today in that venue would not pass muster. Now, I'm not saying we're doing a research project, but if I took this research project as being written in Washington, it would be rejected from the human subjects. I would be told, you cannot do this research. First of all, there's no equipoise. I had to throw in a fancy technical term. There's no uncertainty. We know from large amounts of data, from real practice in many countries, that single payer or a system that uses not-for-profit insurers and gives everyone the same insurance as an alternative to single payer, so very similar in terms of keeping everyone with the same insurance and without the profit motive. We know that those all work, yet we don't have any real evidence that what we're proposing now works. You can't do this. You could hurt a lot of people. Substantial risks to participants, risks of not getting insurance, of not getting care, risks of morbidity and mortality. And since I started with jumble, I will end with inadequate conformed consent. much as we are trying to channel what's going on to you and make it understandable, it is essentially incomprehensible. Even Ken, who knows what's in the specific bills, doesn't know how it's going to come out. So there's a little bit of unpredictability. I leave you with that thought.